Hi everyone, welcome back to your channel. I love pharmacology. In this session, let us learn about the anticholinergic drugs which are nothing but the muscarinic receptor antagonist. Myself, Dr. Padmanabha T S. So these are the questions you need to answer at the end of this session. You can go through it, you can pause the video and you can go through these questions. Once you have gone through these questions, let us understand what are the difference between anticholinergics and antimuscarinic drugs. We'll also see the understanding of atropine fever and atropine flush. What is the difference between meiotic and the mydriatic? What do you understand by cycloplegia? And what is the difference between depolarizing blockade and non-depolarizing blockade? So keeping this in mind, let us start the cholinergic antagonist. So there is no precise term to say cholinergic antagonist or parasympatholytic. So cholinergic antagonist are not parasympatholytic, they never disturb the parasympathetic system. And you can never call it as a anticholinergic drugs because one must remember that anticholinergic drugs means those are the drugs which can block both muscarinic receptors and the nicotinic receptors. So whenever you use a term anticholinergic, that means the drug must block the both the receptors, that is cholinergic, that is the muscarinic receptor as well as the nicotinic receptor. To confine to this chapter, let us understand the drugs which are acting on the muscarinic receptors. So we can divide the cholinergic antagonist into three groups: atropine and related drugs, which are nothing but the anti-muscarinic drugs or the muscarinic receptor antagonist, and they do not have anti-nicotinic action. On the other hand, there are drugs which can block the nicotinic N receptors, which are nothing but the ganglionic blockers, which are present on the autonomic ganglia. And there are some group of drugs which can block the NM receptor, which is present on the neuromuscular junction. These are called as neuromuscular blockers or skeletal muscle relaxants. So please remember, atropine is a prototype muscarinic antagonist. So in this chapter, we'll be discussing about the antimuscarinic agents. So all of the muscarinic antagonists are competitive antagonists for binding of acetylcholine to the muscarinic receptor. Means these drugs will going to compete with the acetylcholine from binding to the muscarinic receptor. If you can increase the dose of the acetylcholine, it can be block can be overcome. So if you increase the acetylcholine dose, you can overcome the atropinic actions. So that's why they are called as competitive antagonists. If you increase the acetylcholine, you can overcome the effects mediated by the atropine and related drugs. And atropine has got no intrinsic activity because in the absence of acetylcholine, they would not have any effect at all. So coming to the classification of muscarinic drugs, they can be natural alkaloids. We have atropine and the scopolamine. Atropine is derived from Atropa belladonna, which is a deadly nightshade, or the Datura stramonium, which is a Jameson seed or the thorn apple. L-iosayamine is having a antimuscarinic activity. When extracted, it will be converted into DL-iosayamine, which is very stable compound. But in DL-iosayamine also, we should remember that L-iosayamine will be a active moiety which will be mediating the antimuscarinic activity. Scopolamine is derived from the Iosymus niger, that is a henbane or Scopolia carneocelia. We have a semi-synthetic drugs like homatropine, atropine methionnitrate, iosine methybromide, benztropine, ipratropium, and the thiotropium. Under synthetic groups, you have many drugs like cyclopentolate, tropicamide, dicyclomine, trihexyphenidyl, glycopyrrolate, procyclidine, propanthalin, pyranzapine, talanzapine, oxyphenonium, clidinium, flavoxate, oxybutynin, tolterodine, fesoterodine, palatamate, and the drotaverine. And there are some group of drugs which has additional antimuscarinic activity. Those are antihistaminic agents like diphenhydramine, promethazine, and the orphanadrine. And one more class of drug is the antipsychotic, that is phenothiazine groups like chlorpromazine and thioridazine. And one more group is the butorphanol, that is haloperidol. And one more group which possess the antimuscarinic activity is the tricyclic antidepressants like amitriptyline and the imipramine. There are something you need to remember at this point of time. The flavoxate can be used for the treatment of suprapubic pain mediated by cystitis and the urethritis. Basically, these drugs will going to relax the urinary bladder. That's why these drugs like oxybutynin, tolterodine, fesoterodine can be used to treat bladder spasm during the urological surgery. It can be given through oral route or via catheter. They can be passed into the catheter that can act at the bladder site. And valethamate can be used in the delayed dilation of the cervix during delivery, mainly for relieving the bladder spasm as well as uterine contractions. And we have a drotaverine, which is again a smooth muscle spasms. It will going to help in treating the smooth muscle spasms, especially the uterine spasms that which occurs during the early pregnancy and dysmenorrhea. Additionally, it has got phosphodiesterase 4 inhibitory action, where it will going to correct the imbalance between the cyclic AMP and the calcium. So coming to the pharmacokinetic parameters, absorption of the atropine and scopolamine are very wonderful or well absorbed to the gut as well as conjunctiva, and scopolamine can be made utilized through the transdermal route as well. So coming to the distribution, they get widely distributed, and scopolamine can cross the blood-brain barrier because of their tertiary nature, which can cross the blood-brain barrier and produces CNS effects. Metabolism: 50% of atropine as well as 80% of the scopolamine undergoes metabolism in the liver as a conjugates, and one must remember that black rabbits are resistant to the atropinic actions. The reason being the black rabbit possess atropine esterases or atropinase enzyme, which makes the atropine degrade in a faster rate. So there will be faster degradation of the atropine. So excretion, usually the 50% of atropine will be unchanged, excreted unchanged in the urine. T off is around 3 hours, and atropine effects rapidly declines except for the eye, which lasts for 72 hours or more. So coming to the cholinergic antagonists, especially the atropine, usually this will going to antagonize the effects of acetylcholine. Cholinergic, as I said, cholinergic antagonists mean these are the drugs which can act on both nicotinic and the muscarinic receptor. But if we are talking about the atropine, that means to say atropine is an antimuscarinic agent. It is not an anticholinergic agent. So prototype drug is the atropine. So all muscarinic antagonists are competitive antagonists for the acetylcholine mediated action through the muscarinic receptors. And coming to the muscarinic antagonists can be classified based on their selectivity. They can be classified into non-selective antimuscarinic agents. We have atropine, scopolamine, homatropine, cyclopentolate, tropicamide, oxybutynin, and trospium, as well as dicyclomine and glycopyrrolate. And also we have a benztropine, triaxiphenydyl, which is a benzexol under the non-selective antimuscarinic agent, which can block all the M1, M2, as well as M3 receptors. We have selective antimuscarinic agents like derifenacin, fesoterodine, solifenacin, and tolterodine, as well as pyranzapine and talanzapine, which will going to block the specifically M1 receptors, and the derifenacin group of drugs will block the M3 receptors. We have antimuscarinic bronchodilators like aclidinium, ipratropium, tiotropium, and umeclidinium. Apart from this, one must remember that now what we talked about the antimuscarinic agents, they belong to muscarinic antagonist. We have a non-selective as well as a selective antimuscarinic agents. If we are including the antinicotinic ganglionic blockers as well as the neuromuscular blockers, then we will be talking about the anticholinergic agents. So extended classification of anticholinergic antagonist anticholinergic drugs includes antinicotinic ganglionic blockers like hexamethonium, trimethophan, mecamylamine, and antinicotinic neuromuscular blockers we have a succinylcholine and the D-tubocurarin. So coming to the anticholinergic or the antimuscarinic mediated effects and the side effects. On the eye, it produces mydriasis and cycloplegia, where it acts on the circular muscle fibers and blocks the circular muscle fiber activity. Thereby, there will be unopposed action mediated by the alpha receptor, alpha 1 receptor, which is present on the radial muscle fibers, leading to dilation, which is a passive mydriasis. Cycloplegia, there is say blockade of the M3 receptor present on the ciliary muscle, thereby it causes cycloplegia. There will be loss of accommodation, which can lead to blurring of vision. In the skin, it decreases the secretion, decreases the sweating, and there will be flushing because of the vasodilation. So it reduces the sweating and the flushing. So gastrointestinal, it reduces the motility as well as it reduces the secretion of the gastrointestinal tract and the cardiovascular system. Initially, it may cause bradycardia due to action on the M1 receptor, but the higher doses it produces tachycardia by antagonizing the M2 mediated action on the heart. Respiratory system, it produces bronchodilation and decreases the bronchotracheal secretion. Genitourinary, it will cause urinary retention because of the bladder relaxation. Central nervous system, it can cause drowsiness, hallucination, and the coma. So usually the side effects will be the dry eyes, dry mouth, blurred vision, and the constipation, as well as the urinary retention. So what are the clinical uses of the anticholinergic drugs? So they can be used in the treatment of motion sickness, drug-induced Parkinsonism, peptic ulcer, and as an antispasmodic agent. In case of asthma and COPD, as a pre-anesthetic agent. In case of urinary stress incontinence, organophosphate poisoning, fundoscopy in case of children, as well as fundoscopy in case of the adults. You can use atropine derivatives and to break the adhesion between the iris and the lens, and also in the treatment of heart block and the sinus bradycardia, and also to diagnose the Alzheimer's disease. In motion sickness, we use a scopolamine which blocks the M3 receptors in the labyrinthine and vestibular pathway. Thereby, it blocks the transmission of the impulse or the vomiting impulse into the vomiting center. Basically, it is given in the form of transdermal patches which will be applied behind the ear, and it will cause steady state release of the drug 0.5 milligram over 3 days. Usually, it is given for prophylaxis of motion sickness. Drug-induced Parkinsonism, we use benzatropine, benzexol, bepiridine, and procyclidine. It will going to take care of tremors, rigidity, because cholinergic activity will be more when compared to the dopaminergic activity in case of drug-induced Parkinsonism in the basal ganglion. It will going to help in treatment of the extrapyramidal symptoms due to the antipsychotics, where there will be increased cholinergic activity because it blocks the dopaminergic activity. So peptic ulcer and antispasmodic, we have peptic ulcer, you can use pyranzapine, but better drugs are available now. And antispasmodic, we can use dicyclomine, etc. Asthma and COPD, again there are better drugs, beta agonists are available, but you can use ipratropium and tiotropium along with the inhalation of corticosteroids, the newer drugs being aclidinium and imeclidinium. Pre-anesthetically, to reduce the secretions, you can use glycopyrrolate more commonly than atropine and scopolamine. Glycopyrrolate causes less tachycardia and other side effects will be less. And scopolamine has got advantage of producing amnesia and tranquilization. Stress incontinence, you can go for the vesicoselective antimuscarinic agents like oxybutynin, tolterodine, derifenacin, solifenacin, fesoterodine, and propionine. This can be remembered in the form of mnemonic called as SOFT, that is solifenacin, O oxybutynin, F for fesoterodine, and T for tolterodine. Soft bladder, that is the D stands for the derifenacin. Organophosphate poisoning, atropine is a drug of choice, and atropine can be used to treat organophosphate compound poisoning, but not the carbamate poisoning, because in case of carbamate poisoning, the cholinesterase enzyme sites will be occupied. There are two sites, acidic site and the anionic site, which will be occupied by the carbamate. Whereas the organophosphate compound poisoning, the anionic site will be vacant, where atropine can bind to that anionic site and can displace the cholinesterase enzyme as well as the organophosphate compound separately. So fundoscopy examination in case of children, so you can use atropine, not the atropine derivatives, because atropine has got strong anti cycloplegic action, and also because in case of children's, they have strong ciliary muscle tone, they can withstand the effect of atropine. Whereas in case of adults as well as elderly individuals, you can go for omotropine, cyclopentalate, or tropicamide, which are shorter acting. Because if you give atropine, its action will last for around more than 7 to 10 days, and it will be very problematic, and there will be blurring of vision for 7 days or 10 days. To break the addition of the iris and the lens, you can use the omotropine, cyclopentalate, tropicamide alternatively with the miotic agents. And atropine can be used to treat the sinus bradycardia because it will cause tachycardia. For the diagnosis of Alzheimer's disease, you can use tropicamide eye drops, which causes unexpected marked pupillary dilation in case of Alzheimer's disease. So these are again the uses of anticholinergic agent. Apart from the other uses which we discussed, they can also be used in the treatment of mushroom poisoning and also in the treatment of muscarinic side effects mediated by the neostigmine while treating the myasthenia gravis. And also it can be used as adjuvant in the treatment of irritable bowel syndrome as it causes the decrease in the motility. So these are the some other uses. Coming to the adverse effect profile of the anticholinergic agent, what are the mnemonic to remember for atropine toxicity? You can remember it as dry as bone, hot as pistol, red as beet, blind as bat, mad as hatter. It blocks the thermoregulatory sweating, thereby it causes increase in temperature hypothermia, or it is called as atropine fever, hot as pistol. It is more dangerous effect which can be encountered in children and potentially lethal in case of infants. It also blocks the secretion which can lead to decreased sweating and salivation, lacrimation will be significantly reduced. That's why they're called as dry as bone. And moderate tachycardia will be present, and higher doses it can cause arrhythmias as well. And CNS side effects it includes amnesia, amnesia, delirium, or the hallucination. This is referred to as mad as haters, and dilation of the cutaneous vessels of the arms, head, and neck and trunk will lead to atropine flush, red as beet, and they're contraindicated in case of acute angle closure glaucoma because it will going to cause the mydriasis and decreases the aqueous humor flow, and it can cause urinary retention, especially it will be problematic in case of the BPH individuals and the elderly males. It can cause blurred vision as well as photophobia, referred to as blind as bat, and also it can cause constipation. So, how to treat the anticholinergic toxicity? Atropine toxicity can be treated with the help of isostigmine, which is a drug of choice, which is a tertiary alkaloid, which can cross blood-brain barrier as well, which can overcome both the peripheral as well as central effects of the atropine. Along with this, you can use cooling blanket as well as evaporative cooling to treat the hyperthermia. And coming to the anticholinergic and antimuscarinic differences, anticholinergic means these are the drugs which can block both muscarinic and nicotinic receptor, whereas antimuscarinic blocks only the muscarinic receptor. Atropine fever means there will be hypothermia, where the reason being there is a reduction in the sweating. Atropine flush is mainly mediated by the cutaneous vasodilation. Mydriatic means it is dilation of the pupil. Cycloplegia, there is a loss of accommodation because of the paralysis of the ciliary muscle. Depolarizing blockade, it causes flaccid skeletal muscle paralysis. The reason being it causes persistent depolarization of the neuromuscular end plate. Whereas the non-depolarizing blockers, those are the D-tubocurarin, which blocks the nicotinic neuromuscular end plate receptor and prevent the end plate depolarization. So coming to the answers for the questions. So which is the prototype drug under anticholinergic or the antimuscarinic agent? It is your atropine. Natural alkaloids are atropine and iosine. And whether, sorry for the spelling mistake, whether atropine is a competitive or non-competitive antagonist, atropine is a competitive antagonist. Prophylactic drug for motion sickness is scopolamine. They are applied through transdermal patches. It causes tachycardia. Drugs for bradycardia and AV block again atropine, in which poison atropine is a drug of choice in case of OP compound poisoning as well as muscarine poison. And drug to overcome atropine toxicity or atropine overdose, physostigmine. A mnemonic for atropine toxicity is dry as bone, hot as pistol, red as beet, blind as bat, mad as hatter. Effect of atropine on eye, it produces mydriasis. It produces mainly the passive mydriasis. Can you tell in the comment box which drug can cause active mydriasis? Atropine is used for fundoscopy in children. Why? Because ciliary muscle tone is high and there is no cycloplegia in case of children. Atropine is not preferred for fundoscopy in elders. Why? Reason being, the atropine being a longer acting drug, it produces blurring and photophobia, which can last for 1 week. Vasospastic anticholinergic agents and uses, it can be remembered as soft bladder, that is solefenacin, oxybutinin, besoteratodine, tolteratodine, and the derifenacin, used for urinary incontinence in case of pregnancy as well as dysmenorrhea. Vasospastic anticholinergic agent which is having phosphodiesterase 4 inhibitory action, that is the drotaverine, and drugs which dilates the cervix during the delivery, that is the valatamate, and the bronchodilator anticholinergic agents are ipratropium and tiotropium, which is used in the form of inhalation route. Drug-induced Parkinsonism, we have a centrally acting anticholinergic agents like benzatropine, benzexol, piperidine, and procyclidine. Pre-anesthetic medications, we have atropine, glycopyrrolate, and scopolamine. And shortest acting mydriatic will be your tropicamide, followed by the cyclopentolate and the homotropin, and longest will be the atropine and the scopolamine. So this was all about the anticholinergic agent. If you find this video useful, please do subscribe to my channel, I Love Pharmacology, and do not forget to share and hit the like button for more updates on pharmacology. Thank you.